and you'll mix it and centrifuge it, what we were doing 15 seconds, your hospital may do 20, just depends on the kind of centrifuge they have. And then you'll look for agglutination. If there's not any, we call it compatible, move on with our life. It takes 5 minutes, so it's super fast. And so all you're gonna detect at immediate spin is ABO incompatibility. And so what class of antibodies will be detected at immediate spin? IgM. You need to know that for the test. All this is detecting is IgMs. It's not, you're not going to detect any IgG antibodies at immediate spin. And then this part about they can only be done if they don't have an antibody now and have no history of an antibody. You need to know that for the test too. So this first part. Yeah, that's what, you need to know when this is allowed. Only if they don't have any history or a positive antibody screen today or a history of ever. The antiglobulin test is all phases. You do an immediate spin, then you incubate it, and then you wash it, go through AHG, which is adding the green liquid, spin it down, and read it again. So that detects clinically significant IgG antibodies. So you have to do this if they have a positive antibody screen today, or if they've had one ever in the history of them coming to wherever you're at. Even if their screen's negative today, and they had an antibody 10 years ago, you have to do a full cross match. The computer is gonna tell you what you have to do. And so if the patient has an autoantibody, most of the time this is just done at reference labs, so you would have sent a sample out. Unless they teach you how to do this, which I've never done before. The auto. Computer cross matches, which is the easiest kind of cross match you're ever gonna do. So the computer has this logic where it takes the patient's ABO type after you've run the specimen and put in the results, and it lets you pick a unit. So you do somebody's blood work and they're A positive, you can pick a random. If their screen's negative, their antibody screen is negative, and they've had a negative antibody screen forever, as far as your computer knows, you should be able to pick any random A positive unit off of the shelf, scan it in, and the computer's gonna know that it's the same blood type and that it's okay to give it to them. So you never have to pull a segment or anything to do any kind of testing. You just give them, you just pick a unit off the shelf, scan it in, and the computer says it's okay. Sounds scary, right? As long as their antibody screen is negative and always has been, it should be fine. So the recipient must not have had an antibody or antibodies in the current sample or ever. And then the barcodes give you another measure of safety. So everything is barcoded. You just scan everything. Everybody probably doesn't do these computer cross matches because it takes a lot of background work with the computer people, so the LIS people, the lab information people, and then they have to validate it, make sure it doesn't make any mistakes, so it takes lots of testing in the background to make sure it works. So that's when you can do it. It was very scary coming back from maternity leave, and they were doing computer cross matches, not doing any cross match. I like to see in the tube that my cross match was compatible, because I knew. And then here they were just scanning units and slapping a patient tag on there, like, here you go. The first time I did it, I was like, I don't like it, I don't like it. But then I began to love it, because even Rulo can make it look like a positive cross match. Like, Rulo will look like agglutination. Well, I never had to worry about Rulo again. It was amazing. No saline replacements, none of that, because I just scanned the unit and gave it to them. There was Rulo, I didn't know it. It was great. You're gonna love it. So, an acceptable cross match doesn't mean it's gonna be a successful transfusion, because that is just lightning. Adverse transfusion reactions may still occur. A negative antibody screen doesn't mean that they don't have an antibody, because sometimes they go away. Like the kid antibodies are the worst about it. And a compatible cross-match doesn't guarantee the survival of the red blood cells. So even if they're not having a reaction, like they're not sick, if their red cells from the transfusion don't live as long as they're supposed to, then that's still a negative impact of the cross-match. Like that's still technically a transfusion reaction. So some of the risks that can occur that aren't life-threatening is allergic reactions, reactions to the white blood cells, and so there's a whole chapter on adverse reactions. Some of the symptoms can be hives, itching, low-grade fevers, chills, and so they can be to drugs that the donor was taking, or their white blood cells if there are a few in there. So all of that stuff can happen from a transfusion. Recipient blood sample. So that's the patient. The patient identification and sample labeling. Patient and sample information should have two independent identifiers. So name, date of birth, medical record number. Most of the time now, when I started in the lab, we hand labeled blood bank tubes. So you went up there, you drew a pink shot from the patient, and you got your little marker or your pen, and you wrote all the stuff that was on their armband on that tube. If you made one mistake writing down that medical record number, which is usually 10 numbers long, if you made a mistake, you had to go back and draw it again. It sucked so bad. So you couldn't make a mistake. It's terrible. Now, almost everything is barcoded. And so you'll go in the room, you have a printer, and so you'll scan, and a scanner, and you'll scan the patient's armband, and the orders have already been placed in the computer, and your labels that you need are gonna print out, and they're stickers, and you just slap a sticker on there. It's amazing. So that's how it usually is now.
Hand label everything.
So that's not the case everywhere. If you have to hand label it, don't make a mistake. At Spring Hill, you're not gonna have to, unless the system goes down, then you're gonna have to. Providence, that's where they had those computers. Providence, you shouldn't have to. Some places that may still do it. Make sure you know the difference in surname and forename, because if you mix them up, then it's wrong. It's still wrong. Forename is your first name. Remember, they both start with an F. That's something I didn't know. I was too scared to ask in front of the patient because I didn't want to look stupid. I mixed them up because I didn't know the difference. I never had to use that word before. And I got down there and it was wrong. The blood bank was like, that's not right. Come on. Give me, it's my first time. Give me a break. They let me slide, but they told me they wasn't going to do it again. I'm like, everything else is on there. It's date of birth, it's medical record number. Can you please give me a break? Scared to death. Then I really looked stupid. I should have just asked in the room when I was with the phlebotomist before I made the blood bank thing. I was an idiot. Came a long way, right? You can use serum or plasma. What we're always using in the blood bank right now is plasma. That's probably what you're going to use, the pink top. The age of the sample, the limit, 3 days. If the patient has been recently transfused or pregnant, most places just use the rule of 3 days no matter what, because it's too hard to keep up with who's been transfused and who hasn't. So 3 days is just the rule, unless your facility has a policy otherwise. Hemolyzed samples or samples contaminated with IV fluids must be recollected. So if a phlebotomist draws a blood bank tube, can they take it back to the blood bank and label it up there? No, that goes in the garbage. How to do it, you need to know that for the test. Samples have to be labeled at the bedside. I have caught new phlebotomists standing right outside the blood bank labeling their tubes. You can tell them right then If you don't wanna be confrontational, just stand on the other side of the window and wait for them to bring it to you, and then you cancel it and order another one. Just, no, you can't use it, you cannot use it. So if there's things going on in the background that you don't know about, then you'll never know. But if you see something bad happening, you have to stop it. Because you're the one that's gonna be doing the cross match. So this is another reason, because people do wild stuff because they just don't understand. A lot of us don't have the blood bank background that you're gonna have. And so, you just have to watch out for weird stuff. Forgot what I was gonna say, but AABB makes you have 2 determinations of a patient's blood type before you can transfuse. So they come into the ER, they don't have any history at your facility, they draw a pink top, you run it, they're A positive. You can't transfuse off of that sample. You have to get somebody to go draw another tube from a different time. It'd be really cool if it was a different person. Run it again, just for their group and type, so determine what their blood type is. After you get that second determination, so I proved that they're A positive, then you can transfuse. Because you're not gonna kill an O person if you give them an O, or if you give an A or a B person an O unit, but if you give an A unit to an O person, you're gonna kill them. And so AABB says you have to determine everybody's blood type twice from 2 separate collections, no matter what. Phlebotomists and nurses get mad. I already drew it. Why do you need another one? Because we're gonna kill them if we give them the wrong blood type. If you came up here and labeled your tube and we didn't know it, and you put the wrong person's name on it, we're gonna be the ones that kill somebody. It's very important. So that's why you just have to explain it to them when they lose their patients, when you ask for another tube. Because they get mad. Because it's more work for them. They don't understand why. So, where was I? So the sample can be used for a cross match for 3 days, but it has to be kept in the blood bank for 7 days. At least 7 days. So Kristen, how often do y'all throw your tubes away
I've never.
in the regular lab?
Hematology is every day, chemistry is every 3 days.
Yeah, so do you think that just random core lab people are tossing blood bank tubes? Only blood bank throws blood bank tubes away because you have to keep them for at least a week. And so nobody, the blood bank tubes are kept in the blood bank, that way nobody else has access to them. Blood bank is like an island. So you need to know this for the test. Cross matches are good for 3 days. Samples are kept for 7 days. So even if you have that sample in there from 7 days ago, if you need to give them a transfusion after 3 days, you're gonna get a new sample. And the computer's not gonna let you cross match something, hopefully, on an expired, it's on an expired sample after 3 days.
And why are we keeping it for 7?
In case, good question. Why do we keep it for longer than the 3 days?
You can still run other tests on it.
Well, if they have a transfusion reaction, because a part of a transfusion reaction workup, and we're gonna talk about those in the adverse reactions chapter, which is not long, I don't think. You have to repeat all of the testing, the testing in the beginning, to make sure there wasn't a mistake. And so you have to keep that sample. I mean, they say you can have a transfusion reaction up to 2 weeks later, before the patient really knows that they're having one. But at least 7 days. What do you do if the sample's not properly labeled? So you get it, it's missing some of the information, half the medical record's cut off. You have to discard it and reorder it, get another tube collected. Cannot use an improperly labeled sample in the blood bank. That may be a question on the test. If it's not labeled, if it's missing information, or if it's not labeled, or you see them label it in the hallway, you have to get another one. It goes in the garbage. You can't keep, don't even hang on to it, because you don't want anybody to use it on accident.
Is this one of the things that like the blood bank veterans will just be like, that's okay?
No,
They'll actually turn it away?
yes,
Good.
For 1 mother.
every single time too. And the phlebotomist will hate you. It is what it is. But the phlebotomist is not gonna kill them, you are.
Yeah, it's gonna make you just get in trouble.
Yeah, oh yeah, they can take you to court. If you kill somebody, you can be subpoenaed, you can't hurt anybody. I don't want that to scare you, but you have to make sure everybody else is doing the right thing too. Don't let anything slide in the blood bank. Okay, previous records. Current ABO and D-typing must be compared with results performed over the past 12 months. We looked back, if they were born, the Spring Hill opened in 1975, if they were born there, we looked all the way back to 1975. I looked back as far as I could find, because I wanted to know anything I needed to know. So, I guess they say at least 12 months. I would look back as far as I could, and the computer does it for you. So previous records must also be consulted for any significant event related to testing or transfusion. So whether they had an antibody, whether they had a transfusion reaction, even if it was mild and they was itching. The doctor will usually, in that case, just order some prophylactic medicines like Benadryl or Tylenol or something. So you just have to look at everything. And you do that just by typing in their medical record number and searching their history in the computer. So it's not like you're digging through files, hopefully. Now, when I did start, they had a filing cabinet with index cards in it. I know it sounds like this was like the dinosaur days, but things have come a long way even since I started. That was just 10 years ago. But you dug through this little box with index cards in it that were in there by alphabetical order, and you looked for your patient to see if they had a problem. So we really only did that with really old patients, like if they were like 75 and older, like stuff that was really old. Eventually, we got all that stuff put into the computer system, but when I was digging through there, I found my grandmother's sister, who was probably like 80s by then. I don't even know if I ever remember meeting her, but I knew her name, and I thought that was so cool. So things now, hopefully, it's all computerized. So repeat testing of donor blood. Whole blood and red blood cells must be retyped to confirm the ABO labeling. So the people that are labeling these units at the blood center, they're human. What if they made a mistake? So every unit that you bring into the lab, so the blood center usually delivers blood every morning to the blood bank in a box on ice. And so there's rules about how much ice, like so many pounds per how many units, and they weigh it and put it in the box, and it's literally just on ice. ABO testing is performed on all units. D testing is only performed on the D negative units. This is done at the donor center, so they determine if it's weak D. If it's weak D, how do you think they label it? It's RH positive. Because you can't chance giving any D positive blood to a childbearing age female. That's the most important population as far as the D goes. So you only repeat the D testing on D negative units. So somebody that was working with me from this program in the blood bank, after I became supervisor, was doing a D test on all of her RH negative units. I mean RH positive units. Because you don't have to do it on the D positive ones, right? So it's only performed on D negative. Because we're trying to prove that it's D negative. Just to make sure. So she was doing it on all of her RH positive ones, which you don't have to do. And so I didn't know she was doing that. And so she's sitting over there and she's like, we have a problem. I went, what? And she's like, this one says it's A positive, but I'm getting A negative. I went, it took me a minute to realize what she was even doing. I was like, what? And so I looked and I was looking at her results and I was like, why are you doing the RH on this RH positive unit? If they're RH positive, it doesn't matter. If it's labeled as RH positive, we're not gonna get it to an RH negative person, so you don't need to check it again. And so I asked her why she was doing it. She's like, well, I always do it. I'm like, well, they're probably weak D positive, which you wouldn't have had to worry about if you wouldn't have been doing it. And so she had been doing that for years and nobody knew. That's the first time that she came across one that was weak D. Stop. I was like, don't do that again. You stop it. Don't make any more problems than we already have. You only have to do it on the D negative units. Does that make sense? So it says records are kept for 5 years. There are different things that have to be kept for different lengths of time. Your antibody workups, I am pretty sure they have to be kept indefinitely. So the supervisor is gonna keep up with what you have to keep and what you don't. And it all goes to this off-site storage that nobody knows where. And if, like say you have an inspection and they request, oh, I wanna see your records for this from whatever year, then you literally send a courier with the information, like it's in this box, labeled this, wherever, and they go get it. They go get it. So you can always go, send somebody to go get your records. They keep them for a long, long time. And it's in a different site, because all of that information is gonna be in your computer system. But if your facility burns down, say the hospital burns down, there goes all your records, so they require you to keep them in a separate place. Okay, pre-transfusion testing. So testing you do on the patient before they can get the unit of blood. ABO and D-typing. You have to resolve discrepancies before your transfusion, so if there's an ABO discrepancy, like a subgroup or something. Antibody detection, we already know that for patients, we only use unpooled, which means single donor screening cells, and that's what we used yesterday, and that's what we're gonna do. Our panel, you'll see there, the donors R1, R2, or whatever, that's just one patient's phenotype. Each cell is from one person. And cross-matching demonstrates ABO incompatibility, and so this is what's done in immediate spin. Oh, I'm dyslexic. And clinically significant antibodies at the AHG phase. And so this detects the IgGs, this detects the IgMs. And so you have to know for the test, which tests are included in the routine pre-transfusion compatibility testing. It's the ABO, D-typing, and then antibody screen. Do they do a DAT? Only if you get a positive antibody screen. So DATs are not done routinely.
What's the word in between routine and testing?
Routine compatibility.
Compatibility.
ABO typing, D typing, which is called RH typing also, and the antibody screen. So mamas that are pregnant, this is what they get. Pre-transfusion people, so somebody needs blood or might need blood, this is what they get. ABO and D. So these, I just consider these together. That's part of their forward and reverse, if you ask me. And then the antibody screen. Why are these people screened for antibodies also? To look for red cell allo antibodies. So that might be on the test. So they're screened for antibodies. So we technically just said that. They've made from exposure to red cells, either through pregnancy or transfusion. That's the ones we're worried about. So this chart, you're gonna get practice on this with your homework. So you can use this if you need help. So compatibility, and you've seen this before, for whole blood, red blood cells, and plasma. Whole blood, we know has to be type specific, because it has plasma in it, it has red blood cells in it. We know that just packed red blood cells, so these are considered packed red blood cells. The plasma's taken off of it at this point. This one still has the plasma in it. They take the plasma off of this. And so they can have, an A can have A or O, because anybody can get O, so they can have their type plus O. Bs can have B and O. ABs, because that's why they're considered the universal recipient, they can get any. And then Os can get just O's. O's can only have O's. What if there's no O's on the shelf and you need blood for an O person? There is no alternative. So that's why they don't give O's to anybody that they don't need to give them to. So if you have an emergency, what are you gonna give? O. You're gonna give O. And so they're using blood at an alarming rate. They've already gotten 6 units of your O blood. What are you gonna do? You're gonna type them as soon as you can, and if they're an A, you're gonna switch them. The goal is to not deplete your O's. So as soon as you determine their blood type, which you really need 2 determinations, once you get that, you're gonna switch them. Plasma, A's can get A and AB, B's can get B and AB, because AB is the universal for plasma. ABs can only get AB. O's can get any. They'll have a chart in the blood bank, visual, where you can see if you need to make a decision, like, for a different type. Just an interesting fact, from my blood center, ABs costed more, $25 more, I think, than all the other types. Why do you think? There just wasn't as much supply of the ABs as there was with all the other blood types. And so ABs costed more where I worked, well, from my blood center.
So you said AB is universal for plasma?
Yes, anybody can get AB plasma. Anybody can get O blood.
So it's flipped.
Yes, it is. So selection of donor units. For the D antigen, D negative units should be given to D negative people, especially children of, women of childbearing age. So where I worked, we had a 200 bed hospital, we kept 10 O negs on the shelf, at least. Sometimes we had a hard time keeping that many. Let's see next. We kept 45 O-pods. So, if we only had 10 O-negs, we would really save them for the females, the childbearing age females. If we were running low and a woman that wasn't 50 yet needed blood and she was O-neg, say she was in surgery, we would look and see if she had a hysterectomy. If she's had a hysterectomy, she's not having any kids. So the blood supply can get so bad that you can't get blood, that you barely have enough to go around. So we would, if we knew they were in surgery for a hysterectomy, you have to prove that they're having a hysterectomy. Sometimes hysterectomies do use blood. It's not that common, but I have seen it happen. We would switch their type if we were low on blood, because 10's not many. If I got below that, if I got down to 7, I started to get nervous. And so, if their childbearing age is the most important, now you have to prove, and you have to talk, I would talk to the pathologist, so I would go, which is the transfusion services medical director is what we had. And and I would walk around her office, hey, so-and-so's in surgery, they're having a hysterectomy right now, I confirmed with the doctor. Can I switch her? I only have 7 O-negs on the shelf. So that's the kind of decisions you have to make in blood bank. And it's not always the case, but for some reason during the summertime and around the holidays, the blood supply gets pretty slim. And so I have seen it happen, and in COVID it got bad too. Antigen negative blood should be given if they have an anti-D antibody. So once you switch them, D is the most immunogenic, you switch them to their O neg, you switch them to O pos, the likelihood of them making an anti-D is pretty good. Once they make one, then you have to give them D negative blood, because they have an antibody. It is hemolytic. I didn't even understand that at first. I'm like, well, what would happen? D is gonna be hemolytic transfusion. Once they make that antibody, you have to give them O negative for the rest of their life. So that's the worst that can happen, or A negative, whatever type they are.
So if they're O negative, you can get them in hospital?
You can. When you do a cross match at immediate spin, even through AHG, if they haven't made an anti-D, it is gonna be compatible. Because it's okay. It's okay until they make an antibody. So, and some people just don't make an antibody.
So once you switch them, they went from positive to negative, and they have to be negative.
Once, say it again,
Like if you switched them
from what to what?
from negative to positive.
Yeah.
So from anything in the future, they'd have to get,
Negative, only if they make an antibody.
okay.
So you, say somebody's in heart surgery, they're O negative. So they used to order 6 units on, you don't have to know any of this, 6 units on heart patients. They're O neg. If somebody is considered a heavy user, which means they use more than 3 units in a 24-hour period, and that was just our policy. Make sure you are familiar with your policies. They're gonna make you sit down and read them all. You're not gonna remember all that. You go back and read it when you need it. We would send up 6 units, say the patient was O neg. And so when I say send up, our heart surgery was like on the 3rd floor, and they had a blood storage refrigerator in there, so before a heart surgery, they would have a perfusion assistant, I think was their job. They would come down and pick up the blood for the heart and put it in the refrigerator up there, which the blood bank monitored for temperatures and all that stuff. To make sure everything, because nobody understands the blood bank stuff like you do. So, we would send the blood up there, they put it in the refrigerator. That way, it was right outside the door of the OR, because if they need blood in heart surgery, they need it right now. So they don't have time to come to the blood bank on the 1st floor and pick up some units. So what we would do is send 3 O negs and 3 O pos. Most of the people that needed heart surgery where we worked were old people. So if it was a female, I would never have sent RH positive blood up there without pathologist approval. We would make sure that little lady, whoever picked up the blood, knew that you have to give these first. When you use those 3 O negs, call me. So sometimes they'll come back for the 3 O pos after, or like after they used 2 of the O negs. Hey, we are using, some heart surgeries don't use any blood. That's great. But if they do start using, usually when they get down to 2, they'll send somebody down for the 3 O pos. They will make sure they give all the O negs first, and then you switch them. So more than 3 in a 24-hour period is considered a heavy user. So you don't have to know that.
So,
But when you see people switching their blood type and stuff in the hospital, there's reasons for why they're doing what they're doing. Because if you give them all of your O negs, and a mama comes in with a placental abruption and she needs blood right now, you don't have any blood. If you have to give RH positive blood, that sucks. Really sucks. So that's why they do what they do. Recipients with antibodies, so antigen negative units are recommended for these antibodies. So those are really some of the most important ones. Remember, some of those on your anagram are not clinically significant. I think that big S and little s should be on that list, in my opinion. But, I don't know, I didn't make the list. Remember, M and N, they're not really clinically significant. You're not gonna worry about those unless they show up at AHG. So when you get low on O-neg, you'll call the blood center first. Do you have any? Sometimes they don't. If you know you're gonna need some, you can call the other hospitals and ask them, hey, how many O-negs do you have? Can I get one? Can I get anything?
What if it's not the same company, like, you know, Senior River or, and they don't?
Oh, yeah, no. In Southern Mobile, none of the hospitals are in the same system, except for Providence is fixing to be part of USA, right? That's what I've heard. But, yeah, no, it doesn't matter. So sometimes the doctor will order, anybody can get any type of platelet. Sometimes the doctor will order a type-specific platelet for a certain reason. And if you don't have a, most people keep less than 5 platelets on their rotator. So if you need a type-specific platelet and you don't have it, that's what you would do. You'll call the blood center first, and they can call around for you, or you can just call. You can call the other hospital. So I'm at Providence, I'm across Spring Hill. Do y'all have a O-positive platelet that I can get? Like, I'll trade you one, whatever. So that's stuff that the blood bank does. Tagging blood products. So that's requirements for the tag after you've cross-matched a unit that is for a particular patient. So it has to have their full name and 2 independent identifiers. Usually it's gonna have more than that. It'll have the name of the blood product. So like leukocyte-reduced blood product, so it'll be called LFR. Leukocyte filtered red blood cells or whatever. So there's different kinds of platelets. So it can be apheresis platelets, whatever it is, different kinds. Cryo, precipitate, FFP. And so the unit tag, so if you're gonna stick it on the unit by either it'll be a sticker, or some of them actually use printed tags that print off on this typewriter sounding dinosaur machine. That's what we used. You'll attach it to the unit. It'll have the unit itself will have the donor number on it, and the tag when it prints off, it'll have it on there. It has the unit's expiration date, the ABO and D typing, the interpretation of the cross-matching. It better say compatible. And then the technologist identification, so it'll say Peyton Hartman and his number on there. There's no question about who did any of the workup. Just saying. If it's electronically cross-matched, the tag will say that too. It's gonna, all the information's gonna be on the tag. So issuing blood, so that means the person that's gonna come to the window and pick it up. So you have to have a physician's order. You're never gonna cross-match blood without the order. Who it's supposed to go to, the identifiers, their ABO and D type. The requisition form, usually it's just a patient sticker off their chart. If they show up without a sticker, and without knowing what type of blood product they need, send them away. They need to go back and figure out what they're picking up. If they don't know what they're picking up, then they don't need to pick it up. Compare the requisition form with the donor unit tag, so the sticker with the tag when you pull the unit out of the refrigerator. Check the expiration date, which is gonna be stuff in the computer probably. It's gonna make you do like hit a OK button or something. Visual check of the unit, so is it discolored, is it clotted? So don't be scared to look at it. Like, touch it, look at it. If it looks purple, sometimes that means there's bacterial contamination. If it's clotted, you're gonna see a big clot. If it looks funny, don't use it. I've never seen a red blood cell that looks funny, but I've seen some weird looking plasma that I thawed it out and had a big clot in it. They transfuse blood through a filter. The clot's gonna stop the filter, like it's gonna clog up the filter, and then they're not gonna be able to use that line. And so if it has a big chunk in it, just put it to the side, you can't use it. If there's any special transfusion requirements, like do they want irradiated? Do they want type specific? HLA matched, which, okay. I only saw HLA matched order one time in my whole career. There's all kinds of special stuff. Sometimes they'll won't see them be negative. So just watch, so you'll see the special requirements on the order when it comes in. You'll get the blood product ready, you'll see the special requirements in the computer. You'll see it on the tag when you go to issue, because you set it up, doesn't mean you're gonna be the one to issue it. They may issue it on the next shift. So,
What is type specific?
so if they say they're A positive, an A positive person can get any kind of platelets. Platelets do not have to be type specific. But the doctor, if he orders it type specific, then you have to. You have to give them what they order, because there's a reason that he needs that patient needs something special.
So like exactly A positive.
You would have to get an A positive platelet. If you don't have one on the shelf, call around and find one. You have to just let the nurse know, I don't have one, you call the nurse at that point. If they ordered a type specific A positive platelet, if you don't have one, call the nurse. Hey, I don't have one, so that's letting her know, don't show up right away, I need a few minutes. Then you call around, say, I'm gonna try to get one, I'll let you know it's here. Don't bother me again, is what you're really saying. I'll let you know. Okay, unused blood products. Blood products may be reissued, so the nurse picks it up, they change, she gets up there and they're ready to transfuse, and the doctor says, no, I don't wanna do it right now. Bring it right back to the blood bank, as long as they haven't opened it. If the unit has been kept between 1 to 10 degrees, that's the range for storage, and we'll talk about that in that chapter. If it was stored at room temperature, it has to be returned within 30 minutes, or within a time frame determined by the facility. When I first started working, they said 30 minutes. But if that unit is warmer than 10 degrees, you can't use it anymore. We took the 30-minute rule away, and we had a infrared temperature thing. And you would check the temperature of it when the nurse brought it back, and if it was out of temperature, then you quarantine it, you can't use it. Anything that you waste, you still have to pay for. And so it costs money. A unit of red blood cells was a couple $100 when I left. And even though it's free, it's donated blood, right? They have to do so much testing on it and traveling it around to where it's supposed to go. So every little bit of that costs money. And sometimes it goes on an airplane and then it comes back. So that's why blood is so expensive. The hospital pays for it if you waste it. So if the nurse picks it up and it goes out of temp, then the hospital pays for it. The insurance, hopefully, or the patient gets charged for it if they use it.
Yeah, but I was thinking like if it gets wasted.
No, you can't charge the patient for that. Insurance will fine you about $1 million. I don't know, it's a lot of money. You can't, that's the insurance fraud. Can't do that. So they usually just measure the temperature when they bring it back. So if the nurse will call you, because they don't understand, they do not understand any of this. They don't know how hard it is to get blood, none of it, they don't understand. So they'll call you, hey, doctor doesn't want to use it right now. You will tell them, you get it back right now. Even them holding it in their hand while they're walking it to the floor can make it go out of temp. You tell them run. If you can't, I'll meet you. I'll come get it. Where are you? And I would run. Don't waste my blood. I'm the one that's in there stressing out because I don't have enough already. They shouldn't pick it up unless they need it, but things happen. So that question I asked you a minute ago about what do you do if a type O needs blood and you don't have any, you need to know that for the test. But you need to know that in general. If there's no O blood and you have an O patient, there's no alternative for the O person. An emergency release, which is also called an urgent transfusion, is a transfusion that is needed before the blood bank work is done. Sometimes they'll need the blood before they even draw the pink top. Like a gunshot wound, we saw those in Mobile, there's gunshots all the time. So the release must be signed by the physician. It's a real piece of paper. When you do the emergency release, you'll put all the patient stuff on there and give them the piece of paper. The nurse or the doctor has to sign it. Our paper had a place for the nurse and the doctor to sign, and so AABD said if it has places for two signatures, they both have to sign. So I was in the process of taking the nurse's part off because getting both of them signed was like, I mean, it's a circus, especially when there's an emergency. The doctor has to sign the paper. You know why? Cause if they have a transfusion reaction, he's liable. He's the one that's making the decision that the need to transfuse is more important than waiting on the cross match to be done. So if something bad happens, he's going to court, not you. He has to sign that piece of paper. If he don't sign it, you have to keep looking for him the rest of the day until he signs the paper. He has to sign the paper. The paper has the patient's name, the identifiers on it, so you'll tag the units. It'll say emergency release, whether it was partial cross match, no cross match, usually it's no cross match. I don't even know what that means. You're not gonna give blood to anybody that you know is, I don't know what that means. It'll have the donor unit numbers, and so you don't have to write all that down. The donor unit has stickers on the back. You just pull a sticker off and stick it on there.
Will blood banks contact people that donate infectious blood and tell them like, hey, you know you have this?
So
right?
they'll put them on a list where they cannot donate anymore. So even if they did give a unit, they're not gonna call you out in front of everybody, they're gonna throw it in the garbage.
Like an email?
But they'll send them a letter. They'll send them a letter, not an email, a real letter in the
A real
mail.
letter.
And they'll tell them, don't come back here no more.
They're not gonna break up with them under.
No, yeah, they're gonna send a letter, because they want them to go to the doctor too if they need to go.
That's the carrier pigeon.
You keep segments from those units, because once that unit of blood goes away, and you finally get the pink top, and you wanna do your cross match, you can't. The blood's gone. And so, as a rule, they usually pull segments from every unit that's issued, so that you don't forget. And so the segments from these emergency release units, you'll have special units set aside that are ready to go. The tags are already partially filled out with all the donor information. That way it's easy to just grab them and give them to whoever. And the segments are already pulled, and you'll just set them to the side until you get a tube. And then you have to put the name of the person who issued the unit on the tag, because that stuff, all that stuff's not in the computer yet. The patient just rolled in the ambulance, and they need blood right now. So as soon as you get a specimen, you start doing the cross match and doing our ABO type. If at any time you find out that something is not compatible, call them and tell them. At that point, it probably doesn't matter, there's nothing they can do, but they can be looking out for a transfusion reaction, at least they'll know. Sometimes, if a patient is so sick, if they're needing an urgent transfusion like that, they can't wait on the cross match, their immune system might be so busy that they won't even have a reaction if they're that sick. And so, I mean, that can be a good and a bad thing. Massive transfusions is when you replace their total blood volume in a 24-hour period. So group O, D negative is given in emergency in the beginning. Usually now, if they're only child-bearing female, which is 50 years or younger. If a D negative unit is unavailable, you can give D positive, which is what they really do, especially for men, to reserve the D negative blood, just for women. And once they determine the patient's blood type twice, then they will switch them to ABO identical. So if they're Rh negative and they have switched them to Rh positive, you've already exposed them. So they'll just keep giving Rh positive blood until they make an antibody, because at that point it's too late. So I've seen them do that too, especially when there's a blood shortage. If you've already exposed them, it's too late. Just keep giving them Rh positive. You're repeating the screen every 3 days already. And so until they start making an antibody, just give them Rh positive. But that's if your policy allows you to do so. This maximum blood order thing, it's like how many units that you will do for certain surgeries. So hip surgery, say they need 2 units on standby. AABB has the general, this is how many you should do, and then the surgery committee will come together and say, well, this is how many, because we know how much blood we're using, so they'll do like some math and figure out how many they need. We're almost done. So typing and screening. So that's what's done for people that need surgery and pregnant women. So ABO, Rh, and antibody screening. They usually do a typing screen for surgical procedures. that need less than 1 unit of red blood cells. So that means they didn't do a cross match. They just have a typing screen on standby. If you're doing an electronic cross match and they're in surgery, they decide that they needed a unit of blood. If you're doing an electronic cross match, it takes about 1 minute to get a unit of blood labeled for the patient. It's because you're using the computer, you just scan it, it's super fast. And so if they're doing a circumcision, they're not gonna set up units. They're just gonna have a type screen. If they're doing a hip surgery, they're probably gonna set up a couple units. Circumcision, I almost said it again. Cross matching is performed on a sample if blood is needed. So autologous blood, that's if you're getting blood that you donated to your own self. So they will have procedures to make sure that if somebody donates to their self, that you don't accidentally give it to somebody else. You save it for them for when their surgery day comes. If they don't use it, you still leave it on the shelf until it expires. Then you throw it away. Nobody can get it but them. If they don't use it, just hang on to it till it expires, and then it goes to the garbage. The process is monitored through the computer, and so hopefully the computer will keep you from accidentally giving it to somebody else.
Let's say I went and donated it to myself, had my surgery, everything went good. The blood that I donated to myself was still good. Could I say, okay, y'all can have it?
No.
No?
Mm-mm. Now, if you needed it at another time and it was still good, you could, I don't know how you would go about it, but you would still be able to maybe get it to wherever you are. Say you're at a different hospital. Maybe you could still get it. I would just go back to the same hospital if you know you have blood there. But usually, once they have their surgery and go home and they don't need it, I've always seen it expire on the shelf. So infants younger than 4 months, we didn't transfuse babies, maybe y'all will get to see it. ABO and D-typing must be performed, they don't have to do the serum typing. So why do you think?
They don't have antibodies.
They don't have their own antibodies yet. Okay, so I saw somebody run a baby sample on the machine and they manually programmed it. So the automated label, it tells the machine what to run. So it would do a group and an RH. So it would do a forward only, right? Do the ABO and the RH. When they manually programmed it, something happened, and they manually programmed the sample, and they did it to do a group and type. The results came off, and if the forward and reverse don't match, the machine goes crazy. It shows you, hey, something's wrong, you need to look at it. Well, they did the forward and the reverse on a brand new baby, because it was an accident. They were used to programming it on all the samples. And they were like, whoa, something's wrong, something's wrong. And I'm like, wait a minute. And I looked at it and I saw the results didn't match, and I was like, how old is this person? And I looked and it was a brand new baby. And I was like, don't look at the reverse. Don't even put that in the computer. It won't even let you put that in the computer. Like, that's your problem. It's got mama's antibodies. The baby had a different blood type than the mama, and it had mama's reverse antibodies in its plasma. It's gonna make your life hard. Can you use dad's plasma for if they needed to do like a cross match or something? No. So if I ask you that on the test, no. Babies or mamas? If the mama has an antibody, you have to give units that are negative for that antigen to the baby. So if the mama has a red blood cell antibody other than ABO, so say she has a KELP, which is one of the common ones in women, which is really not that common, you give the baby KEL negative blood. Because the mama's antibodies are still in their plasma. Non-red blood cell products, so frozen plasma, which we call FFP, fresh frozen plasma. Platelets, cryoprecipitate, they do not need to be cross-hatched. So you just tag it, it's easy. Plasma products should be ABO serum compatible. Cryo and platelet does not have to be ABO compatible. It can give any type. Of these two. Oh, not those two. These two. Any type. That's terrible. Yeah, cryo and platelet can be any type. Unless the doctor orders type specific, which he's only gonna do for platelets, because that's a cellular product. Cryo is not. So apheresis platelets and granulocyte concentrate, so you can give somebody white blood cell transfusion if they need a granulocyte. We did not do that. Probably really big places do that. They need to be cross-matched if they contain more than 2 mils of blood. We didn't take platelets that were visibly contaminated with blood, so we didn't have to worry about it. We didn't do any kind of platelet cross-match. So that's stuff that they'll do at the blood center. I've never even seen that before. The reason platelets don't have to be cross-matched is because they don't have enough plasma in them to cause a problem. They shouldn't have any red cells, and they don't have enough plasma, because it's just a little bag of platelets, and with some of that liquid that's in there is the preservatives, and the, I guess the anticoagulant, whatever they put in. It's different than what they put in blood. So I only have one question I want to ask. XM means cross match. Oh. Oh, wait. So if you cross match a group O patient, so you're using the patient, you're gonna be using their plasma, right? With group A red blood cells, what phase of the cross match would you first detect the incompatibility? So remember the phases are immediate spin, 37 degrees, AHG.
Immediate spin.
Yes. That's what the immediate spin cross match is for. Immediate spin is just to detect ABO incompatibility. So you're gonna know it right away.
We're gonna be able to see what that looks like in the tube.
It's just gonna look like a big lump, like it's gonna agglutinate, so maybe we can probably do it, yeah. Any agglutination, which is what is gonna happen, means that it's gonna do the same thing in the body. I mean, technically, the immune system's gonna remove them from circulation, but this, in the tube is kinda showing you what to expect.